Hello, everyone. My name is Dr. Stephen Cole, Associate Professor here of Economics, and welcome to the 2025 Marburg Memorial Lecture. Before we begin, just a couple brief announcements. One, after the presentation, we'll have two mics, one set up in this aisle, another one set up in that aisle, and we'll have about 15 minutes of Q&A, so feel free to come down and ask your question to Janet. Number two, if you'd like to view a recording of the lecture, or if you know someone who would have liked to attend but couldn't, we'll post a recording on the Marburg website afterwards for you to watch. Thank you. So just a little bit about the Marburg Memorial Lecture, the history of it. This is a distinguished annual event hosted by Marquette University to honor the legacy of Theodore Marburg, a longtime member of the economics department. The goal of this lecture is to provide a forum for the discussion of moral, philosophical, and social dimensions of economic issues, as well as continue Professor Marburg's commitment to the economic aspects of peace and justice. It serves as a platform for intellectual exchange between faculty, students, and the broader community, reinforcing Marquette's commitment to thought leadership and Jesuit values of learning and service, making this lecture a hallmark of scholarly excellence at Marquette. The lecture is made possible by the generosity of the Marburg family and through the support of the Center for Applied Economics. And now I'd like to introduce Dr. Sarah Feldner, Acting Provost and Executive Vice President of Academic Affairs here at Marquette University.
Thanks so much. It's great to be here, and I was commenting earlier. Working at a university is a beautiful Friday, but it is a world where we're surrounded by ideas and the interconnections of that. And so I know there are a lot of students who are here. I imagine some by choice and some by obligation. But I will say I hope you allow yourself to be curious and allow yourself to think about how what you're studying connects to the world we're involved in. So thanks for letting me be part of it today. And it's really my pleasure to introduce the speaker this year, Janet Curry. Janet Curry is a professor of economics at Yale University and the co-director of the program on families and children at the National Bureau of Economic Research. Curry is a pioneer in the economic analysis of child development. Her current research focuses on socioeconomic differences in health, environmental threats to health, child mental health, and the long-run impact of child health. She has presented her work at universities around the world and in venues ranging from the White House to the European Investment Bank. She holds honorary degrees from the University of Lyon, the University of Zurich, and the Università della Svizzera Italiana, and is a member of the U.S. National Academy of Sciences, the National Academy of Medicine, the American Academy of Arts and Sciences, and the British Academy. She was the 2024 president of the American Economic Association and is a distinguished CES fellow and a fellow of the Econometric Society, the Society of Labor Economists, and the American Academy of Political and Social Science. She was chosen as a Nomis Distinguished Scientist in 2019 and won the Klaus J. Jacobs Research Prize in 2023 and was named the Clairvaux Citation Laureate in 2024. Just give me a run for my money here. In 2015, she was named one of the top 10 women in economics by the World Economic Forum. Curry has served on the board of reviewing editors of Science, as the editor of the Journal of Economic Literature, and on the editorial boards of many other journals. One notable fact that I was given about the Marburg Lecture is it's a very proud tradition here at Marquette University, hosting some of the most influential voices in economics. So influential, in fact, that 2 of the past 5 speakers have gone on to win a Nobel Prize in economic sciences. So no pressure for this year's speaker, but we're really excited to welcome, and we do expect great things from Dr. Janet Curry.
So hello, everyone. Thank you for that lovely introduction. Thank you for coming out today. It is a beautiful day, so I know you have other options, and I'm glad that you chose this one. I'm going to talk about investing in children to address the youth mental health crisis. So this is something that we've all heard a lot about. It's been described by the previous Surgeon General, Vivek Murthy, as the defining public health crisis of our time. And if you think about it, that's really remarkable. We just came out of COVID. I thought that was the defining public health crisis of our time. But no, this is worse in some ways. The American Academy of Pediatrics has declared a state of emergency with respect to children's mental health. So there's a lot of attention on this issue right now. In this talk, I'm going to do three things. First, I'm going to tell you about the economic costs of the mental health crisis. So this might address a question that some of you may be asking yourself, which is like, why is an economist studying this anyway? I'm going to show you it's really costly. Then I'm going to turn some attention to what I'm going to characterize as two myths about the mental health crisis. So myth number one is that this is a new thing. I'm going to show you that it isn't. It's been around for decades. The second myth is thinking about youth suicide in particular, which is one of the worst manifestations of the mental health crisis, that it doesn't actually track very well with other measures of mental health. And the reason why I'm going to argue that that's important is because it suggests that there's other things that might be affecting youth suicides that we could look at. So there's things that we could do. And then on the third part of the talk, I'm going to talk about the evidence about things that can improve youth mental health. So hopefully end on a little bit more hopeful note. Okay, so thinking about the costs, one reason why the costs are large is because the numbers are large. So it's estimated that about 13% of US children have a current diagnosed mental or behavioral health condition. Presumably there's other people who have a condition which has not yet been diagnosed. And these child services for the people that have been diagnosed cost $31 billion in 2021, which is almost half of all child medical spending. So again, the reason why it's such a big number is just because there's so many people affected compared to many other child health problems. And so those are direct medical costs. There's also a lot of costs, for example, for parents who are affected and lose work time due to their children's problems. Okay. Now, interestingly enough, that 13% estimate is very similar to what UNICEF estimates the number is worldwide. So they estimate that 13% of 10 to 19-year-old youth worldwide have a mental health disorder. And so I want you to keep that in mind. The mental health problem in the US does not seem to be worse than the mental health problem elsewhere when we look at mental health diagnoses. But one thing that is a lot worse is the suicide problem. So here what I'm showing you is data from the World Health Organization mortality database on trends in suicide in the US compared to a 27-country European Union average. Okay, so what you can see is that in the US, there's a lot of things you can see here. One is you can see that there's a big gap for males and females, which is an interesting thing to keep in mind because we know that females are more likely to be diagnosed with mental health conditions. Okay, so right away you're seeing this sort of gap between what goes on for suicides and what goes on for diagnosed mental health conditions. Another thing that you can see is that the rates recently are higher than they have been since about 2008, but about the same as they were in the 90s. Okay, so we had a previous period where we had high suicide rates and they came down, and now they've gone up again. And I think that's also a useful thing to keep in mind. And then you can see that the levels are higher than they are in the EU, and the trends are also different. Right? So in the US, we've had increasing suicide rates. In the EU, it's going down. And at the same time, in the EU, people are talking about mental health crises as well. So diagnoses of mental health conditions have gone up. Right? So there's this kind of disconnect that I want you to think about with respect to what's going on with suicide and what's going on with other measures of mental health. And I'll talk a lot more about that. Okay. Now, thinking about survivors of mental health crises, this is also very costly. We know that about 50% of adult mental health conditions start in childhood, and that child mental health conditions are more predictive of negative adult outcomes like lower educational attainment, lower probability of working, lower earnings, than a lot of common physical health conditions. This is an example using actually data from Canada, comparing children who have mental health conditions to their own siblings who don't. And so along the bottom axis here, a bigger number means that somebody has a worse mental health condition. And the y-axis is whether they're still in school at age 16 to 19. So you can see the numbers generally slope downwards, which is indicating that people who have mental health conditions are less likely than their own siblings to still be in school at ages 16 to 19. So that's just one illustration of the costs. Okay. Also, this is also from some work using Canadian data, where here what I'm trying to do is to compare the effect of having a mental health condition, in this case ADHD or conduct disorders, with the effects of having two common physical health problems, asthma or a major injury. And so the outcome I'm looking at here is whether people went on social assistance after age 18. And what you can see is that the orange line indicating the mental health conditions is a lot higher than the other two lines, indicating that it has a greater effect on the probability of ending up on social assistance. And one more example. This is US data looking at people who go on Social Security disability. And you can see the causes that are listed. The blue bar is for mental health conditions. The red bar is for musculoskeletal conditions, so those are all the people with back pain or joint problems. And then the green, circulatory nerve problems, sensory problems, and then the other bar is everything else. So you can see that mental health problems are a huge explanation of why people have disability. Okay, so thinking about these myths, the first one that I mentioned was that there's been this rapid and unprecedented increase in child mental illness. And I think the timing here is really important when we're thinking about causes. One of the main reasons why everybody thinks that there's a child mental health crisis caused by social media is because of the timing. They think, oh, well, this happened really recently. What's one thing that changed in the world? Well, it's social media, so it must be that social media is what's causing this child mental health crisis. Okay. So this is sort of Exhibit A. This is a 1970 report to the US Congress using exactly the same language about the crisis in child mental health, in this case, challenge for the 1970s. And in this report, they estimate that 10 to 12% of US children had major psychological problems, really similar to that 13% number that's currently estimated. Okay. Similarly, in 2000, the Surgeon General had a big conference called for national action and estimated that 11% of children were suffering from significant impairments from a mental health disorder. Right? So rather than this being a completely new thing, this is something that has existed for decades, and every now and again, it sort of returns to the public conversation and the public limelight, and we think about, well, maybe we should do something about it. Okay. Now, these high pass rates are not so surprising if you think about what we know about the causes of mental health conditions. So we know that some people have genetic vulnerabilities, that they tend to run in families, but it's not enough to have a genetic vulnerability to have a condition of some sort. Usually there's a trigger, usually there's an environmental factor of some sort. So some of the environmental factors that we know about are things like severe maternal stress while a child is in utero. The paper that I'm referencing here was looking at mothers who had a death in the family while they were pregnant, and they compared those mothers to mothers who also had a death in the family, but after the pregnancy. Right? So all of the families suffered a death in the family, but only some of them had it happen during the pregnancy. And they found that those children were more likely to be taking antidepressants as young adults. Okay? Also, we know stressful events in early childhood, like having poverty, having a lot of problems in the household, are associated with future mental health problems. And there's even a literature looking at environmental triggers like pollution, nutritional deficiencies during pregnancy, and showing a link there with mental health conditions. Okay, so I'm arguing that this really hasn't increased as much as we think. Right? So then why is everybody talking about it, and why are the measured rates so much higher? And so I'm going to do a little bit of a deep dive here into talking about changes in measurement and also changes in incentives. Since I'm an economist, we talk about incentives, right? Well, patients have incentives to get diagnosed or not, and doctors have incentives to give them a diagnosis or not. So I'm going to talk a little bit about those things as well. And so what this timeline is showing is a lot of different things that happened over the period 2007 to 2016 that could have had some impact on the reporting of mental health conditions. And so the main point here, I'll go into some of these things in more detail, but the main point is that there's something that happened almost every year that might affect the reporting in some way, including the passage of the Affordable Care Act, which gave a lot of people health insurance who didn't have it before, and then they had means to pay to see doctors or to get treatment. Okay, so thinking about changes in measurement, a really important one occurred with the 2013 change to the Diagnostic and Statistical Manual of Mental Disorders, or called the DSM. So the DSM-5 changed the definition of many mental health disorders. One of the things that it did was to add new conditions to the definitions of anxiety and depression. So you can think of it as sort of a consolidation of a bunch of different diagnoses. So for example, for anxiety, post-traumatic stress disorder used to be its own thing, and then it got lumped in as a form of anxiety in the DSM-5. So you can see mechanically, if I have two separate things and I put them together in the same bucket, then I have more things in that bucket. Right? Similarly, with autism spectrum disorder, this combined 4 separate diagnoses into one new diagnosis, and that greatly increased the reports of people that had autism. Like, people still think about it as autism, but now it's actually these 4 different things grouped together. And then, another example, to be diagnosed with ADHD, the diagnostic criteria used to say that you had to have symptoms starting before age 7. Okay, so if you didn't have symptoms starting before age 7, if your symptoms started at like age 10, you shouldn't be diagnosed with ADHD. Okay, so the change was to change that threshold to age 12, and just with that change in the threshold, the prevalence rose from about 7% to almost 11%. Okay, so there's a lot of changes in definitions going on, which we don't talk about a lot, but probably had a major impact on measurement. Okay, and now thinking about these incentives, okay, on the patient side, what incentive does a child or their parents have to get a mental health diagnosis? Though there's some positive things you can get. You could get treatment, which might be good. You could get an individualized education plan at your school, which might have some advantages. So there's some advantages. On the cost side, what's the main cost of having a mental health diagnosis? It's all the stigma that's associated with mental health problems. And there's still a great deal of stigma, but it's been falling over time. So this very interesting study by Pescondolito and co-authors looks at data from the US General Social Survey, and they actually ask periodically about people's attitudes towards other people who have mental health problems. Like, would I want to be friends with such a person? Would I want to avoid them? Do I think that there's a biological basis for mental health problems? And the answers to those questions all show kind of greater acceptance of people with mental health problems over time. Now, that's a good thing, but it also means that more people are talking about it, more people are willing to admit to having a mental health problem, and that again could increase measured rates. And then, as I mentioned, we have the expansions of health insurance coverage, which mean that some people who previously couldn't afford to get treated, and like, if you can't afford to get treated, what's the point of being diagnosed, can now afford to get treated, and so now have more of an incentive to come forward and get diagnosed. Okay. So to think about some of these incentives and how they play out in data, I'm going to show you some examples which are from something called the Nationwide Emergency Department Sample, or NEDS. And the reason why it's useful to think about emergency department visits in this context is that most people who are having a mental health crisis are advised in an emergency to go to the nearest mental health, to the nearest emergency department. Okay, so a lot of people are going to show up there, at least initially, and then they might get triaged and sent somewhere else. This data is a 20% sample of all the hospital ED claims. It represents 39 states and DC, so it's about 30 million ED visits per year. Now, if you just plot out all the ED visits that have a code that indicates a mental health disorder over the period of time that it's available, it starts in 2006, you see a pattern that looks like this. The first line here is for mood and anxiety disorders, and these have all been normalized so that they start at 1 and then go up. So the fact that that's a 2 at the end is saying that we had a 100% increase in diagnoses of mood and anxiety disorder. Okay? Then the middle line, though, is for any mental health disorder. So the number of people who have any mental health disorder went up 37%, much less. And then the bottom line is saying, if I just divide up any mental health disorder into 2 groups, one being mood and anxiety and the other being every other mental health disorder, I see that every other mental health disorder actually went down a little bit. Okay, so what it looks like is happening here is that some things that used to be diagnosed as something else are now getting diagnosed as a mood or anxiety disorder. So you have these changes over time in how we assess a similar condition. You also see that this kind of bifurcation is true for both males and females, but you have a bigger increase for females, especially in mood and anxiety disorders. And you also see all of these lines kind of track until 2011, and that's when the split happens. So it looks like maybe there was something that happened in 2011 that changed the way that people were reporting these kind of illnesses. Okay. So one important thing that happened in 2011 was that the U.S. Preventive Services Task Force recommended screening women and girls annually for depression. And along the same time, the Affordable Care Act mandate that insurers pay for things that the USPSTF recommended kicked in. Okay, so we have a mandate saying you have to screen for depression, and another mandate saying insurance companies have to pay for that. Okay, but this applied for girls and not for boys. Also importantly, depression screeners usually include questions about suicidal ideation. Okay, so we can see that if we look at boys and girls, we get this split showing up right in 2012, right after we start this screening mandate, where we see girls being more likely to be diagnosed with suicidal ideation than boys. Okay, so again, they track each other exactly until 2011, and then start to split. And then you see both series go up again in 2016 for both boys and girls. And I'm going to argue that that has to do with another change, which is a little bit arcane. But starting in 2007, Medicare, which is the health insurance policy that covers elderly people in the US, started increasing payment for more complicated cases. What makes a case more complicated? Having more diagnoses on the same visit. Okay, so in particular, they increased payment for cases that had a secondary diagnosis of mental illness. Right? So if you think about it from the provider's point of view, maybe I'm treating somebody for diabetes. If that person is also depressed, that might make it harder for me to treat their diabetes, so I get reimbursed more for doing that. Okay? Now, Medicare only covers people over 65, not children, but there's evidence that these changes in coding spill over to other insurers and other patients. Right? So if a provider is changing the way that they're coding something, they don't only do it for Medicare, they do it for the rest of their patients. And along with this, in 2015, you had a change in the International Classification of Diseases, which is how diagnoses are coded, which encouraged the coding of suicidal ideation as a secondary diagnosis for the first time. Okay? So, yeah, going back to here, you can see that when this change kicked in 2016, you suddenly have this big increase in suicidal ideation, and that coincides exactly with this change in the International Classification of Diseases, instructing people, if somebody has suicidal ideation, you should code that as a secondary diagnosis. Okay. And then looking at this distinction between primary diagnoses and secondary diagnoses, what does that mean? The primary diagnosis is supposed to be the thing that brought you there, and then the secondary diagnosis is anything else that maybe is wrong with you at the same time. You can see most of the increase is actually in the secondary diagnosis, which is the middle line here. The top line is any diagnosis, and then the bottom line is people who have a primary diagnosis of mental health. So that really hasn't gone up nearly as much. Okay, so we have a lot of changes in reporting going on here. So just to summarize, two main points. One is that this youth mental health crisis has really existed for decades. And the second one, using this data from the emergency department, shows that diagnoses of any mental health condition grew a lot more slowly than diagnoses of mood disorders, that some of the increase in mood disorders is from relabeling of other conditions, and that a lot of the increase in mental health diagnoses is coming from greater reporting of these secondary diagnoses. Okay, so myth number 2, I'm characterizing this as the idea that the main determinant of variation in teen suicide is differences in underlying mental health. And again, I think this is really important because if there's other factors that are contributing, then maybe those factors could be addressed. Okay, so thinking about suicide and suicidal behaviors, one of the issues is that these things are on really incredibly different scales. So the top figure here is showing the suicide rate for 10 to 19-year-olds, which is the bottom orange line, which looks almost flat in that scale. And then the middle line here is ED visits for self-harm, and the top one is the ED visits for suicidal ideation. And now, to make it a little easier to see the trends, in the bottom figure, I've done the same thing where I say, okay, everybody starts at a 1 in 2006, and then going forward, you see the increases. So you can see that suicidal ideation went up almost 6 times. Right? Self-harm goes up about 70%, and suicide goes up 66%. Okay, so just one point here, when you read about suicidal behaviors, they're putting in the suicidal ideation thing, and you're seeing that there's this huge increase. But that doesn't actually track very well with what's going on with suicides. For suicides, you might want to be more selective and look at trends in self-harm. That seems to track a little bit better. Okay. Now, this figure, I think, is really suggestive that there's something else here besides the underlying rates of mental illness. Okay, so this is looking at suicide deaths for 15 to 19-year-olds by state, and you can see just this huge disparity. So in the Northeast, you have rates of like around 5 per 100,000. And then in some of the Midwestern states, you have rates that are 6 or 7 times higher than that. Okay? Now, there's no data that shows that people in Montana have 6 or 7 times the rate of mental illness as people in New Jersey. Right? The rates of mental illness are pretty similar, but we have this huge disparity in suicide rates. You might think, well, you know, I look at that map, maybe it breaks down by sort of urban, rural areas, but you don't actually see a very big difference in trends in ED visits for rural areas, which is on the bottom here, compared to urban areas. Those track pretty well. So it's not true that we have really different rates of mental illness in urban areas and rural areas, at least by this measure. And if we look, say, by region at the differences or trends in suicide rates compared to trends in ED visits for mental health, if you look at the black line here, that's for the Northeast. And so as I showed, or as I'll show in a minute, that has the lowest suicide rate. And then it actually has the highest rate of ED visits for mental health. Okay, so you're showing exactly the opposite patterns there. Okay. Now, I think you can get a little bit more purchase on this problem by thinking about means of suicide or causes of death. So what this figure is doing is looking regionally. And the top line is the total suicide rate, and then all of the other lines are showing the cause of death. Okay, so here the green dots are deaths by suffocation. The dash dot line are deaths by firearms. And then these other 2 lines, which are very low in all of the regions, are deaths by poisoning. So that includes drug overdoses. So that would be an intentional drug overdose, and all other suicide deaths. Okay, so I think this is often surprising to people because we all know that there's a lot of drug overdoses, and those tend not to be as fatal as some other things, so they don't account for a large share of the suicide deaths. But you can see if you look at these different regions, the thing that stands out about the Northeast is a very low rate of deaths by firearms compared to in the other regions. Okay, so that seems to be one of the factors that's accounting for the relatively low suicide rate in the Northeast compared to other places. So to look into this a little bit more, I'm going to show you some work looking at the relationship between suicide deaths, firearm laws, and also depression. So we're going to use data on laws that come from a database that was compiled by somebody in BU's law school. And to categorize these laws into different groups, we're going to use Everytown for Gun Safety's characterization of what are foundational gun safety laws. And then I'm going to show you some results from a regression model where we have the suicide rate on the number of gun safety laws, the percentage of youth who say that they felt hopeless for at least 2 weeks or more in the past year, some state factors, so this controls for any constant differences between states, like how rural they are. This is year factors, so anything that's the same across different states in the same year is controlled for there. Okay. Now, this hopelessness measure is something that you read about in the newspaper, so like Jonathan Haidt talks about this. It comes from a survey that's done by the Centers for Disease Control every 2 years that's called the Youth Risk Behavioral Surveillance Survey. So this is the largest source of health data about high schoolers in the US. And they ask them these 3 questions as part of the survey. So the hopelessness measure is the first one, but I'll also show you some data from the other 2. So the first measure is, during the past 12 months, did you ever feel so sad or hopeless almost every day for 2 weeks or more in a row that you stopped doing some usual activities? So this is very close to the idea of depression, that it's supposed to last for 2 weeks or more, that it's supposed to interfere with your usual activities. Then they ask, during the past 12 months, did you ever seriously consider attempting suicide? And during the past 12 months, how many times did you actually attempt suicide? Okay, so if you plot out that data from when it first becomes available to the last year, which was 2023, it looks like this. Okay, so what you see is that for as long as we've been tracking the data, 30% of youth were saying that they felt sad or hopeless. It goes up quite a bit after 2017 and then peaks during the pandemic. You also see it's like sort of flatter pattern for considered suicide. It goes down and then starts going up in 2009. And then the number that say that they actually attempted suicide is almost 10%. It's almost flat over the whole period of time. Right? So we have a lot of kids saying that, that they were having serious problems and contemplating or even attempting suicide. Now, comparing those time series patterns again to the pattern for suicide, I pointed out before we have this U shape. It's interesting to look at the end. So I was pointing out that after 2017, the hopelessness measure went up, and you can see that the actual suicides is going down. Right? So again, the things are not lining up very well. Now, these Everytown for Gun Safety foundational laws, the groups that they have are whether it's a background check or a purchase permit, whether there's a red flag law, so that's a law that allows law enforcement to take guns away from somebody if there's deemed to be a risk to themselves or others. There are secure storage or child access prevention laws. There are laws that require permits for concealed carry, and then there's this category of what are sometimes called shoot first laws or stand your ground laws that kind of change the requirements for using firearms if there's a conflict. Like, do you have the obligation to try and solve the problem some other way, or if you feel threatened, can you just shoot somebody? Okay. So looking at these laws and suicide rates, you can see Well, first of all, you can see that the percent hopeless does matter. If you have more people in a state and year saying that they feel hopeless, you have higher suicides. Okay? But the number of laws matters as well. If you have more gun safety laws, you have less suicides. Now, this first row here is looking at the total suicide rate, and then I break it down by whether it's a firearm death, whether it's a suffocation death, so that was the second important cause, and then looking at the difference between them. And the reason why I did that was because sometimes you hear people say something along the lines of, well, if you prevent people from killing themselves in one way and they really want to, they will find another way, right? So in that case, if you make it harder for people to get guns, well, maybe they will do something else. Okay? But what we see, in fact, is that if you pass these gun safety laws, you get a reduction in deaths from firearms and no offsetting increase in deaths by suffocation. I said there doesn't seem to be any substitution here. If you save people from shooting themselves, you've saved them. Okay, so returning to the social media thing, this is something that people talk about all the time, and there are studies showing that college students who are incentivized not to use their devices as much report improvements in their mental health. Not huge improvements, but some improvements. One of the problems for trying to look at time trends in social media use is that we don't have any surveys that ask questions about it in a very consistent way over time. And if you think about it, that's not very surprising because social media is such a moving target, right? It's like now if we were making questions, we might want to ask people about using chatbots, and 2 years ago there weren't any. So it's changing a lot over time. But what I'm going to show you is that in the cross-section, social media use is actually negatively correlated with suicide at the state level. Okay, so this figure is showing the relationship between the answer to a question about the fraction of children who are using social media for more than 3 hours a day and the suicide rate. And you have these 3 outliers down here, which are the same states that I was showing you before, Alaska, Montana, and South Dakota, that have very high suicide rates, okay? So it's not the case that in that map I showed you where some states in the Midwest have very high suicide rates, that has anything to do with people using a lot of social media in those states. If anything, they're using less social media in those states than they are in New Jersey and California, and yet they have much higher suicide rates. Okay, so just to summarize this part of the talk, suicide rates are affected by mental health. I'm not trying to deny that at all. But I think they also importantly reflect other factors such as gun laws. And youth suicides show very different time trends as well as different gender patterns compared to mental health measures. Also, these youth suicide rates vary by a factor of 6 or 7 across states. And that variation can't be explained by differences in mental health or differences in social media use. Okay, so now to the somewhat more cheerful part of my talk, talking about improving child mental health and reducing suicide. Okay, and I think this is really important for people to talk about because sometimes they get the impression that, you only hear bad news all the time. You think there's nothing that the government does that has any positive effect. So it's important to know about the success stories as well as all of the negative things that we hear. Okay? And in fact, the US government, up until quite recently, has been spending a lot more on children. And investments in children went up from about 262 to about 431 billion over the period 2002 to 2019. It's still a bit less than in some comparison countries like the UK, Sweden, and Germany, but it's sort of getting closer. And it's also important to note that on a lot of dimensions, child outcomes have gotten better. So if you look at mortality, for example, there's huge declines in mortality for all ages of children, from infants up to 15 to 19-year-olds. In other sorts of indicators, you see improvements in terms of the number of children who have at least a high school education. Huge reduction in teen pregnancies. It's just basically collapsed. And even looking at things like arrests for violent crime for 0 to 17-year-olds, huge reduction. Okay, so in some ways, the news about mental health is really anomalous compared to what's going on for other indicators of child well-being. And so that makes it more important to determine, okay, which of these investments that we're doing actually seem to have some impact on child mental health. So starting at very young ages, I mentioned that there was literature showing that conditions during pregnancy were linked to later mental health conditions. And so that might be a reasonable place to start trying to intervene. And in some work with Anna Chorney, we've looked at a program called the Supplemental Nutrition Program for Women, Infants, and Children, which provides nutrition supplements, but also other types of support like access to medical care to pregnant women. So we followed children in South Carolina up to age 6 to 11 in their health insurance records. These were all kids on Medicaid. And we compared kids whose mothers were covered when they were in utero to siblings where the sibling was not covered. And what we saw was a reduction at age 6 to 11 in diagnoses of ADHD for the covered siblings compared to the not covered siblings. And also, we've grouped them all together here, but there's a number of other mental health conditions that are commonly diagnosed in young children, and we also saw reductions in those. Also, we saw greater reductions for Black children than for all children, which we think is due to the fact that in the South Carolina sample, it was the Black children who were the most disadvantaged out of all the children. There's also evidence from some work that Nobel laureate James Heckman has done on the Perry preschool experiment, which was an enriched preschool experience for 3 to 5-year-olds. He followed those children up and found that they had fewer externalizing behaviors. So those are things like ADHD or conduct disorders at ages 7 to 9. And then the work that I was showing you at the very beginning links those kind of disorders to higher welfare use later on, lower education later on, lower earnings later on. Okay. Turning to slightly older children, I think the data here suggests that intervening in schools could be an effective intervention. So what is this picture showing? This is looking at suicide rates over the school year for 15 to 19-year-olds compared to 20 to 24-year-olds. Okay, so, and there's 2 different time periods. This is 99 to 04, 2014 to 2019. And so you can see there's 2 peaks here. This is basically March, April, and this is September, October. It's sort of like midterms, right? And you see that this seasonal pattern has gotten sharper over this period of time. And you also see that you don't see the same peaks for the 20 to 24-year-olds. Like this is completely flat here. Maybe there's a little bit more of a peak here for the 20 to 24-year-olds. So it seems to be something associated with the high school. Okay. The pandemic also suggested that in-person schooling can increase suicide. So we heard a lot about how terrible it was for kids to be out of school during the pandemic, and certainly it was terrible for learning, and I'm sure it was terrible for lots of other reasons. But youth suicides actually fell 25% in March 2020 when the schools closed, and then they increased as the schools gradually reopened. And one reason for this, if you think about bullying in schools, people were really worried when the schools closed that this was going to lead to a wave of cyberbullying. But it turned out that cyberbullying and in-person bullying are not substitutes, they're actually complements. So a lot of the cyberbullying is about things that happened during the in-person part of the school day. And so when you had the schools closed, searches for both cyberbullying and regular bullying went way down. This is from some work that I'm doing using schooling in Taiwan. And the reason why we're doing this is because they have very strict school entry age laws. In particular, if you are 6 years old by the time September 1 rolls around, you can go to school. And if you're not 6 years old, you have to wait another year. So what we're doing here is comparing the kids who were born in August to the kids who were born in September, because the ones who were born in August go to school 1 year earlier than the ones who were born in September. Okay? And what we see is that when they went to school, they get an increase in diagnosis of depression. This is for primary school kids. And then we see the same thing for middle school kids. And then sort of looking at the other end of the education cycle, they also have high stakes exams for getting into high school and for getting into college in Taiwan. So when they finish with those high stakes exams, we see the depression treatment falling. And similarly, when they finish with the college entry exams, we see the depression treatment falling. Okay. So the fact that schools seem to be associated with mental health problems suggests that school-based services can help. And there's a very nice study done in Minneapolis looking at the rollout of licensed clinical mental health workers in Minneapolis schools. So they had 19 years of data with 255 schools, 120,000 students each year. And just following what happened to those students after they put the counselors in the schools, they see that offering the mental health services in the schools increased utilization of mental health services, improved discipline, so they had fewer disciplinary problems, and also reduced self-reported suicide attempts. Okay. Some other promising investments in adolescence. There's a very nice paper by Daniel Rees looking at the effect of anti-bullying laws. So most states now have passed an anti-bullying law, which requires schools to take bullying seriously. So if you go to a school with a report and saying, like, I'm being bullied or my child is being bullied, they're required to have an investigation. They're required to talk to the child or the family of the other person that's involved. And he shows that this has that this reduces suicides. Okay. Another important paper by Eliza Yacoum looks at health insurance and mental health coverage. So here she's kind of doing the reverse experiment. Instead of people getting coverage, they lose coverage because they turn 18 or 19 and then they age out of Medicaid. So kids who were taking psychiatric medications when they turn 19, no longer have access to care in her data, and she shows that there's an increase in crime. And then a third intervention, this is in the Chicago Public Schools, is offering cognitive behavioral therapy along with tutoring, shown a big reduction in violence and bullying in the schools and improvements in mental health. And then I've listed firearm safety laws, which we talked about. I think there's a possibility that social media controls or maybe education about social media could have a positive effect, but I don't think we have very good evidence on that. There's also an issue potentially with suicide contagion and how we deal with suicides and whether we deal with them in an effective way that discourages other people or encourages them. But I want to spend my last couple of minutes here talking about treatment. We hear a lot about treatment, that people need access to treatment. Yes, they need access to treatment. But another important thing to keep in mind is that there's a lot of treatment that should kind of raise a red flag. So this figure is from a paper where we looked at children who were all privately insured. It was about 45,000 children, and they were being treated for the first time for a mental health condition. So most of the kids, you should think of the modal kid as like 12 years old and coming in for the first time with depression. And the question is, what treatment did they get? Okay. Well, about 15% of them got benzodiazepines, which is not like a first-line treatment for that. 13% of them got a drug which was not FDA approved for any use in children. So I'm not saying it was the wrong drug for their condition. It's the wrong drug to give to a child at all. 4.3% got an older generation tricyclic antidepressant, which has got more side effects. And then 13% got a combination, right? So they're being treated for the first time, and rather than get one drug, they're getting multiple drugs. Okay, so we estimated that only a little over half of kids were getting a drug that seemed plausible and consistent with guidelines. Okay. We also show that that kind of prescribing is harmful. So in the same sample, we used local provider supply and also local provider practice style, because you see a lot of variation in what kind of treatments people in different locations get. If I'm in a location where many prescribers are prescribing benzodiazepines to children, then the probability that a child gets a benzodiazepine is higher. So we use that kind of variation to explain, what treatment a particular child got, and then we follow the children for up to 2 years and see what their outcomes are. So this figure is trying to show that diagrammatically. And here the outcome that we're looking at is the probability that there was self-harm. Okay? So within 2 years after the initial treatment, do you see self-harm? So this initially surprised me, is that the children who are treated with drugs actually have a somewhat lower probability of self-harm than the ones who are not treated with drugs. But it depends a lot on what kind of drugs that they got. So here we're dividing into 3 categories. The first category is those red flag drugs that I was showing you, things like benzodiazepines or drugs that are not FDA approved for children at all. Then there were drugs that were sort of in the gray area. So these are things which are not FDA approved for children, but are used a lot by psychiatrists. And there are some guidelines from professional societies saying that in some circumstances you might want to use these. And then there's the drugs that are FDA approved. And so you can see that the probability of self-harm is the lowest using the FDA approved drugs, and the highest for the ones using the red flag drugs, and then it's sort of in the middle for these gray area drugs. Okay, so I'm going to stop there and just summarize. My conclusions are, first of all, that the youth mental health crisis is very costly and merits our attention. Also, that this youth mental health crisis has existed for decades. It's not new at all. I've showed you that suicide rates vary with other factors, conditional on mental health measures, and then that there are investments in children that have the potential to improve mental health, reduce suicides, and reduce this economic toll of the mental health crisis. And I just want to conclude, since this is like a heavy topic, I just wanted to give the information if anybody's disturbed or knows somebody who's disturbed and needs help, this is where you go. So I'll quit there and I'm happy to answer questions. Seems like there's a stunned silence. Yeah, so I kind of had the same aha moment twice. So the first time was a long time ago. I was asked to write an article for the Handbook of Labor Economics about the relationship between health and labor supply. And I set out to do that, and I thought, oh, I'm not going to pay any attention to mental health. Who cares about that? I'm just going to look at physical health problems. And then what I realized when I was working on that was that most of the working days lost are due to mental health problems. And the reason for that is because mental health strikes people at young ages, and so working age people are very likely to have those problems compared to a lot of physical health problems which might affect more older people or retired people. Right? So you would think that I would have learned from that how important that mental health was, but then when I started working on mental health of children, like I say, I had the same revelation all over again. I was looking at hospital data, looking at ED data, and it kept popping up that so many ED visits, 13% of all ED visits, have a mental health indication. That's just huge compared to anything else. And so just the fact that it's so important got me interested in looking further.
I had a question about, two questions. One is the rate of suicides and firearms was highest in Alaska, Montana, South Dakota. Those are also states that have the highest percentage of Native American populations as a percentage of the population. Are there, I mean, there are a lot of other factors that impact those populations too, but do you have a control for that? I don't know. Are they equal among the numbers of non-natives, or lesser as a percentage, greater as a percentage?
Yeah, no, it's a really severe problem among Native American populations for sure. And I think this is a big problem generally in public health research. We don't have good data on Native American populations, and also there isn't a lot of trust, right? So if a band or tribe has health data, they don't necessarily want to share it with outside researchers who may, make the situation seem really pathological. So I think there needs to be a lot of work there to sort of build trust, get data, see what the truth of the matter is, and also what can be done. Now, in terms of whether I control for that or not in my regressions, that's the sort of thing that's controlled for by putting in a state fixed effect, right? Because the population that's Native American in Alaska is pretty stable over time, and so that would be controlled in that way.
Hi, thank you for this. I have a question. What role or what did you take into consideration when we're looking at puberty and frontal lobe development that occurs in children ages 10 to 19? And for boys, particularly, the frontal lobe doesn't get developed until 25. And then my second question is, just all the food or the processed food, does that have anything to do with just the sedimentary of kids not going outside, or the whole maybe technology piece of instead of going outside now they're more playing games and not having a lot of that movement? Does any of that correlate with this?
Yeah, those are both interesting questions. So another reason for being interested in mental health is that it does, there's some things that little kids get, but then a lot of mental health things manifest themselves in adolescence. And I think in economics, there's been so much successful research looking at the fetal period and looking at very young children and showing that interventions at that age can be effective, that some people have kind of taken away the message like, oh, but if you don't invest in young children, it's too late. there's nothing you can do for adolescents. So that's why I was trying to list a few of the things that seemed like they have been effective for adolescents. Because I think the reason why we don't know more about that is not because there isn't anything that can be done, but because we haven't done enough research to figure out what are the good interventions for kids of that age. And I think the thing you said about brain development is exactly one of the reasons why we would expect that adolescence is probably a good age to intervene, because we have all of this reorganization of the brain going on. It's another critical period, and so we should figure out what to do for kids of that age. For diet and nutrition and exercise, again, that's a place where we just don't have very good data linking things together. I should look again at the Youth Risk Behavioral Surveillance Survey and see what they have about that. But all the data about obesity and so on comes from the National Health and Nutrition Examination Survey. And that survey, it doesn't have good geographic coverage, it doesn't have good geographic identifiers, and doesn't have a lot of other information besides nutrition. So it's just a matter of we have these pockets of data, and could they be linked together?
So the question that I had was really about, I know you looked at the types of substances that kids are using, whether they're FDA approved or not, or more regulated and acceptable or not. And then also about suicide rate and how it's relatively low by things like drug overdose and stuff like that. But as it relates to mental health and adolescence and all types of things like that with substances, have you looked or investigated to see the prevalence of just generalized substance use in adolescence, whether that be illicit or things like alcohol and cigarette use, but maybe specifically more use of antidepressants, anti-anxiety type of medication, and potentially the use in excess that may be occurring in adolescence, especially if they're diagnosed with a mental health condition in adolescence and begin taking some sort of medication as remedial treatment to that, potentially building up a tolerance over time, and now they're entering adulthood, having to take a medication potentially at higher dosages. And have you investigated generally any stuff as it relates to adolescent use of antidepressant medication long term?
I guess the short answer is probably no, but I don't think that's quite right, in the sense that I have done a lot of work looking at variation in use of antidepressants in particular across areas. I actually have an extra slide in here. Here's my bonus slide about geographic variation in use of antidepressants per capita by county. And it looks pretty random, right? So you have some places where there's practically one prescription per person per year, these being 30-day prescriptions, and other places where there's no prescriptions at all. So we know there's a lot of variation. And we also know that it can be very hard to get off of antidepressants, and so a lot of people who start taking them take them for years. And may be taking them at high doses, and there may be metabolic effects of various sorts. So I think that's an issue where there needs to be more attention as well. A lot of this, if you look at protocols, it'll say, well, you should take the antidepressants for 6 months, and then maybe up to a year, and then if you're feeling better, you should try and get off them. But then nobody helps people to get off them. So people do end up taking them for a long time, and then they also end up getting them, since it's hard to get off, even if it's not working, you may end up staying on that and then just getting another medication added on top, right? So, yeah, I think there just hasn't been enough work done on that.
Thank you so much for this presentation. I particularly really enjoyed the myth of the idea that there's more mental health issues now versus previously that you highlighted. And I think the slide that resonated with me as a clinician was where you highlighted what's happened from a policy level, like Affordable Care Act, mental health parity, and the changes in ICD-10. I think those are all really important. I think another thing I've noticed that's changed over time is the evolution of how we treat and manage mental health, especially from a pharmacologic perspective. from the 90s till now, it's absolutely worlds different, especially when we consider SSRIs. It's sort of revolutionized mental health. And as those drugs have come along, their expansion of use, approval in youth has expanded as well. And I'm sort of curious how that's factored into some of your work, the pharmacology component of drug approvals.
Yeah, so I've really focused. So it's very difficult for me as an economist to say in a typical sort of case like, oh, they shouldn't have been using this drug, they should have been using some other drug, right? I would never have enough information to be able to, or training, to make that kind of a call. So I've really focused on things which seem much more problematic, like I didn't show it today, but antipsychotic prescribing to 3-year-olds, which there's a lot of, right? So there's all these things going on which seem like they definitely shouldn't be going on, and that's where I've spent more of my energy rather than thinking about sort of the modal use.
More like when drugs come onto market and the expansion of what's been approved when, and I wonder if that tracks with how many prescriptions are issued sometimes as well.
Yeah, so a lot of these drugs, the changes recently, say antidepressants, right? Like there's 33 different antidepressants at least. Most of them are now available as generic. There hasn't been a huge change in antidepressants for a while. Atypical antipsychotics came in the 90s. Again, there hasn't really been a big change recently. So a lot of these things, the pharmacological development is all in terms of kind of new formulations or little tweaks, which probably aren't having that much of a therapeutic effect, although they might make the drug more attractive to take for some reason. But there isn't as much of those changes as you might think to try and exploit for research.
First, thank you so much for the lecture and all the information being shared. The one thing actually draws my attention is that I actually excelled the Taiwan high school and also the college rate. Based on the graph, it seems to show that after the college or at least after the high school exam period, the depression and also the anxiety will actually drop. I just wonder, do you think it's the more competitive job market field where actually, and also the social media influence based on how the anxiety being transferred within the job application. Many of our young children right now were kind of exposed to those information. Do you think that's actually going to drop the anxiety, kind of getting another peak after finishing college and towards getting the job?
Yeah, well, I think the anxieties that people have now about getting a job and what the job market's going to look like and so on probably do put more people at risk. I don't know if that would be different in Taiwan, but I guess the other thing I would say about that, I emphasized, one reason for schools to cause mental health problems is bullying. Another one is just pressure. Pressure to succeed, and so that might be going on more with the Taiwanese schools.
I understand. Thank you so much.
Thank you for this talk. It was really illuminating. My question is, when we look at the causes of childhood mental health, you mentioned two that struck me as pretty important. One was maternal stress in utero, and the second was adverse childhood experiences, childhood trauma. So when you were talking about interventions that worked, a lot of them seem to be about counseling of children and services in the schools, as well as traditional medical care like WIC. But my question, I guess, is, have you looked at broader social policies that might stabilize families and give them more economic stability, for example, and then therefore reduce the stress of the mother and that could reduce also the stress of the children as well. So I guess my question is, do you broaden the interventions to think about things that we usually think about as anti-poverty programs and how that might help?
Yeah, I have done some work actually looking at housing because one big stressor is getting evicted from your housing or winding up homeless. And I do have some work showing kind of what you'd expect, that if a family is evicted, that the child is more likely to have mental health problems down the road. There's also sort of an interesting timing thing that it sort of shows up when the child goes to school. Probably the school is noticing that there's something wrong with this child and like encouraging them to get into care. And I also have some work looking at a program in New York to put mental health counselors in the shelters, and that was beneficial. So same kind of idea as putting the mental health counselors in schools. You put them where the families are going to go to get services, and then they can access them more easily that way.
I really appreciate your time spending with us, and I was wondering, well, I know that within the last 5 years, maybe some stigmatisms about schools and what can be shared and talked about in schools have been prevalent. I didn't know if you found in your research whether schools and administrations were overly willing to implement interventions into their programs to help children, or whether that is something that is a little bit similar to the books, where it's different ideologies and different beliefs can cause schools to want to take a step back and not put these programs into place, or whether it's whether that's happening quite often now that people are seeing numbers rise.
Yeah, that's a great question. So I'm kind of enthusiastic about school-based mental health clinics because that seems to be a growing phenomenon, and there's lots of places that have adopted them in different ways. Like some schools actually have a clinic on site. Others coordinate with, say, a community mental health clinic to have workers come into the school a couple of days a week or something like that. But there is pushback to that. I mean, there does seem to be pushback to offering children any kind of mental health care without the parents being the intermediaries. So I have heard of cases where people didn't want mental health services offered in the school because they thought, maybe the mental health counselor is going to, push transgenderism or something like that, right? So yeah, unfortunately, it seems like almost anything can become a victim of the culture wars.